From the Zoomerplex in historic Liberty Village, The Zoomer, hosted by Libby Znaimer.
Welcome to The Zoomer. I'm Libby Znaimer. Today we are taking a close look at a topic that touches countless lives, cancer. According to the latest numbers, this year, nearly 250,000 Canadians will get the dreadful news. You have cancer. More than 88,000 will die. As many in our audience know, I've had 3 different primary cancers, including 2 with stubbornly low survival rates, pancreatic cancer and stomach cancer. I've been very fortunate to recover and emerge cancer-free after treatment. Overall, death rates are declining and more people are surviving up to 25 years after being diagnosed. But there are rising numbers of younger people getting breast and colorectal cancer. And cancer continues to be the biggest killer in Canada. These numbers send a mixed message about the state of cancer today. Malcolm?
The thing that's really driving the incidence of cancer these days is the aging population. Cancer incidences in people below 50 are quite low, and then between 50 and 75, they continue to rise. And I think most people, as we age too, we sort of notice that more people around us are getting cancer. So the increase in incidence is not because of change in lifestyle. If anything, lifestyle factors are getting better, less people are smoking. It's because of the aging population. At the same time, there's been this very slow but definite progress against cancer. And 30 years ago in the 1990s, just over 50% of people would survive cancer for 5 years. Now it's about 65%. So things are not improving as quickly as we'd like, but they are definitely improving.
It's a disease of aging, but more young people are getting it.
There was a recent publication that came out, actually, that was spearheaded by a University of Ottawa radiologist, Dr. Seeley, who reported recently that the rates of breast cancer are going up in young women. The data was quite striking, actually. In the youngest women between the age of 20 and 29, there was a 45% increase in breast cancer diagnosed over the last 35 years. I mean, I think, seeing some of those numbers, we have to look at the absolute numbers as well, because, between 1984 and 1989, the risk of breast cancer in those very young women in their 20s was, 3.9 per 100,000. And that's gone up now to 5.7 per 100,000. So the absolute risk of breast cancer is still low, and that percentage change is low. But I think, so if you're 20 years old and you're watching the show, there's no need to panic, but I think we do need to keep an eye on those numbers, keep an eye on those trends, and better understand why they're happening.
A doctor once said to me, the numbers are the numbers, and your case is your case. And if you're the one, at Nally, you had breast cancer at a very early age.
Yeah, I did not have a close family history of breast cancer, but when I was 37 years old, there was one day I had done my own breast exam on the Thursday, and I found absolutely nothing. And on Friday, my husband happened to find an egg-sized lump in my left breast, just like that. They went from nothing to egg-size. I saw my doctor the same day. That was Friday afternoon. On Monday, by Sunday, it was the size of a baseball. And on Monday, I had a mammogram and a biopsy, and it turned out to be triple-negative breast cancer. So I got treated immediately, and I thought I was good. And then a routine follow-up, almost a year to the date after, showed that it had spread into my lungs. Wow. So I was incredibly lucky. My wonderful oncologist in Kitchener, she had already found a study at Princess Margaret Hospital, so I could go and get immunotherapy done with Keerat. And it had never been tried before in breast cancer patients. And so they found that with this particular form of triple negative that I had, it worked very well. And I've been cancer-free for about 5 years now.
Great. So you get applause for that. Still, there are some cancers that are very stubborn and very low survival.
So I think this trend is also concerning in gastric cancer and pancreas cancer. So although the incidence of these two very deadly diseases is decreasing, we are seeing more and more young patients being diagnosed with stomach cancer and pancreas cancer. I myself, 21 years old, this was 13 years ago, that's when I was diagnosed with gastric cancer. To this day, even though I work in oncology, I still don't really have a reason or an answer for why. That's a scary statistic for me.
You're nodding your head. Do you have an inkling of why?
I'm not sure. As an emergency physician, we routinely are now seeing patients with various types of cancer, including in younger adults, all the way to the older population. But why some of these cancers are increasing, it's hard to know right now.
Well, everybody has a theory. Nobody's proven it. I think that you've got to bear in mind, too, though, that some of the cancers, the overall incidence is decreasing. For example, colorectal cancer in Canada, which is one of the most deadly cancers, the overall incidence of colon cancer has dropped about 4% over the last 5 years. And that's ascribed to screening. And the issue, obviously, with younger people, people less than 50, is that they are not candidates for screening because the incidence is so low. So it's felt that the impact of screening doesn't really influence cancer in younger people. As best we can tell, in colon cancer, where this same trend is seen, it seems to relate to lifestyle, diet, obesity, which are known factors that drive the incidence of cancer.
And it's interesting, and we will get to it. You're talking about young people not being screened, but there's also an issue that the screening stops at a certain age. So I think older people also aren't getting screened, and I think there's ageism in that.
I think there is too, and the focus on age is quite interesting in the younger people, because one of the, a lot has been achieved, but one of the criticisms of the overall cancer mechanism is that everything goes to treatment and very little goes to what's actually driving some of these things, except for the obvious, like aging. And so by focusing on this, I think it's very good. And I think the public, it resonates with the public when people start to build theory and really start to research, what could be going on here. And treating cancer is tremendously important. But, many of the commentators and the public would say, what drives this? We don't understand it. And the decades go by and we're still not sure. So I think it's good, it's getting attention.
Okay. We need to take a short break. When we return, we'll discuss getting a cancer diagnosis in the ER. That's next. Welcome back. It's bad enough to get this news from a doctor you know well and trust, but receiving a cancer diagnosis in an emergency room is becoming more routine in Canada. That's how 1 in 4 new patients find out, and this highlights the gaps in our healthcare system. And Dr. Grewal, you have personal experience of this and you've written about it.
What we're seeing and talking to my colleagues kind of across Canada, we're seeing that more patients are routinely being diagnosed with cancer through the emergency room. So whether it's incidental or they've come in with symptoms that may point to a cancer diagnosis, we are seeing that. And it's not just locally, but we're seeing it more broadly. We're not sure what's driving this. It's probably multifactorial, but we have to think about the current issues with our current healthcare system. We know many patients don't have access to a primary care physician, or there's long wait times to access, say, imaging or specialist support that you need for the cancer diagnosis. So patients may be waiting for that imaging or may not have a family doctor, and their cancer has now progressed to a point where they need urgent medical attention, so they come to the emergency department, where oftentimes we can do the imaging in an expedited way and try and get them follow-up if possible.
What's it like on your end for having to deliver news like this to someone that you've met 5 minutes ago?
as an emergency physician, we don't have a long-standing relationship with patients. We usually have assessed them for 10, 15 minutes and then order testing. And if the testing points to something like a potential or suspected cancer, going back to have that discussion with the patient is likely very distressing to the patients.
And to you?
And to us as well. Like the state of emergency departments, you see it on the news all the time. They're overcrowded, long wait times. We're routinely seeing patients in hallways and waiting rooms. And I think it's so important to have that discussion with their support system. And oftentimes patients won't come into the emergency room with like family or social support because they're not expecting that diagnosis.
I was diagnosed quite a long time ago in 2008 with pancreatic cancer in an emergency room. It was a terrible experience for a whole variety of reasons. And I had a family doctor, and we had started to investigate, but couldn't move up specialist appointments, and there were tests, but it turned out they weren't the right tests. And I mean, that was a long time ago. That was before the pandemic made everything worse.
In my case, I went to the emergency 3 times before I was diagnosed. Yes.
Oh, tell us about that.
So I was 21 at the time of my diagnosis, and it happened to coincide with stressful exams. So I was writing an organic chemistry exam, and that was the first presentation. I actually fainted before my exam. So unfortunately, because of the circumstances and me being a fertile woman, they thought that maybe I was faking it for an exam and that my drop in hemoglobin may have been just because I was a fertile female through menses.
Oh, that's...
Happened again, second time. They said, okay, well, we're seeing a hemoglobin drop. You might be bleeding internally. Go see your family doctor and then go see a gastroenterologist. Saw the family doctor. Gastroenterologist appointment was 6 months later to get a scope and actually identify this bleed. Third time in the emergency department, finally my hemoglobin was low enough for me to be admitted and actually get scoped in through the emergency department. And that's how I was diagnosed.
How awful. So this is not a new thing, though I guess it's been made worse because of the pandemic.
Well, first of all, getting a diagnosis of pancreatic cancer is always an awful experience, wherever you get it. And I think when you've been given that diagnosis or the diagnosis that you might have pancreatic cancer, I think what often patients say is the most important thing is to get from there to what are we going to do about this and when is treatment going to start. And the truth is, if you talk to family doctors, and you've alluded to this, if someone comes back with abnormal blood work, then they have to order the imaging, they have to get a scope, and it's very difficult for them to do this in a timely fashion. At least, as you said, in emergency, you can do the CT scan and you can make the referrals in a more expedited way than going through the family doctor system. And the most important thing we know in cancer is getting things done quickly before the situation deteriorates.
Yeah, I mean, that's definitely true.
It's very true, and it is a strength. But to state the obvious, though, the kind of supports that are required both from family, loved ones, and the system itself to stand with patients, to support them, you know, the emotional side of this gets really fractured when diagnosis occurs in an environment like that, and you're off to a bad start. And then do you fully trust the system? And you know, it is great that it's a quick trigger to something that you really need, but the psychosocial side of it is pretty scary.
Young Adult Cancer Canada did a study a few years ago called the PRIME study, actually examining the psychosocial aspects and financial aspects and other things of young adult cancer patients and survivors, and it frequently does result in a post-traumatic stress situation.
I'm not surprised.
Patients need answers quickly, and they want the testing to be done quickly, and they want to see a specialist who can answer all of their questions, right, in terms of what is the prognosis, what are the treatments like. And at Sunnybrook, for example, we have a rapid diagnostic unit for women who have concerns in the breast. So I think it works quite well in that they're seen quickly, and all the imaging is done and biopsies done, and in some cases even the same day they have a pathology readout. So I think, you know, programs like that, apart from breast cancer, also exist, I think, in lung cancer and other solid tumors.
Yep.
And I think those are excellent programs for our patients.
We need to take a quick break. We'll return with more of the Zoomer. Welcome back. Thanks to advances in prevention, detection, and treatment, Canadians are living for up to 25 years after a cancer diagnosis. So how much of this is because of screening? Kasia, let's start with you.
As we know, if we screen for breast cancer, we can detect it earlier. And if we detect it earlier, that's associated with better breast cancer outcomes and longer survival times.
It's important for colorectal as well.
There are certain cancers where screening is very important. Cervical cancer, which allows you to detect it at a much earlier stage. And the incidence of cervical cancer has dropped considerably, although in truth it should almost be 100% given the techniques we have today. And colorectal cancer, the reason colorectal cancer screening is so effective is that you can actually, particularly with colonoscopy, you can detect polyps before they become cancerous, remove them. And so if you do that, then you basically remove the risk of cancer, almost completely remove the risk of developing cancer over the next 5 to 10 years. So that's why in many jurisdictions, colonoscopies every 10 years, starting at age 50, are recommended. What we tend to do also, though, because we don't have the capacity to offer colonoscopy to the entire population, is we screen for people who are more likely to benefit by testing their stools every year. If there's blood in their stools, which there shouldn't be, then you do the colonoscopy.
But not every cancer gets screened.
That's right. That's right. So I think in women, breast cancer is the most common cancer in Canada, and same with colon cancer. After prostate cancer, it's the most common cancer in men. However, low incidence cancers such as gastric cancer, they do not have the screening in Canada at least. So for example, in Canada, 2024, they estimate only 4,000 Canadians will be diagnosed with stomach cancer, but of those, 2,000 will die within the year.
Wow.
In Asia, because of the screening policies, it is the #1 cancer in countries such as Japan and Korea. So they do prophylactic or preventative screening programs with endoscopies, meaning that they catch them earlier so that they have a higher survival rate for gastric cancer in Asia relative to Canada.
That screening endoscopies, I've had a few, they're very invasive.
They are.
So is that the reason why it wouldn't be expanded, or is it, you think, a capacity issue, Kerry?
Screening's wonderful, but it's helped a lot of clusters, a lot of specific cancers. But there's always the concern that wants to be addressed is, could it lead to overtreatment is one of the concerns as well. And with prostate, there's been a lot of media attention related to, have we got this model right? But I do leave it to the medical team here to weigh in on the ins and outs of that. But I'm trying to address public concerns because I hear a lot of them from people. And I know a lot of men that are saying, I don't even want prostate because I don't want the surgery because it's probably not necessary. I'll stand back from whether it is or not.
I want to get to that in a minute,
Sure.
But have you seen in your work as an emergency physician cases where you're thinking this would have been caught on screening?
Yeah, so oftentimes we'll see both cancers that have screening tests, and I feel like we've done a good job with trying to promote breast cancer screening and colorectal cancer screening, but not everyone's going to opt into those programs. Not everyone has a family physician that can encourage them to go seek that screening. And so I think it's important to recognize that we're still seeing cancers that have screening, but a lot of cancers don't have these screening programs.
Kerry was mentioning prostate cancer. So the test, like the PSA test, is very nonspecific. It's a blood test. And there is a feeling that there's a lot of over-treatment. Also with what's called DCIS, ductal carcinoma in situ, in breasts when it's in the duct. There's watchful waiting now for prostate cancer, but depending on where you are, I know in the States, they'll just treat everything really aggressively.
Yeah, so this is an older audience, it's Zoomer, but if we were to biopsy all of the men in this room, at least a third of them would have prostate cancer in their biopsy.
Yeah.
But the challenge with prostate cancer is that a lot of it is it's almost questionable whether it should be called cancer. It's like what's called indolent It has a very low growth rate, a very low potential to metastasize. And those are the kind of people you referred to who really don't need a surgical procedure with all its attendant complications. And what the field is doing now is using certain factors in the tumor to kind of predict this is a person who needs aggressive treatment, this is a person who can be safely watched. And many men now are on this what's called watchful waiting, where they have a PSA and then periodic biopsies. And as long as things don't change substantially, they never take treatment.
What about DCIS? I mean, I know people who've had full mastectomies for that. I mean, is that still standard?
Well, full mastectomy is not typically standard, not even for invasive breast cancer. You know, more and more, you know, my surgical colleagues do try to do breast-conserving surgery, where people can keep their breasts if that's, you know, medically safe to do so. And we've seen over the years that the outcomes are very similar for patients who have what we call a lumpectomy followed by radiation compared to they have a full surgery. I think going back to the DCIS question, there are, you know, efforts now to try to de-escalate the therapies. So after surgery, you know, historically patients would get radiation, but now there are studies being done to see whether or not some patients, you know, can avoid having some of the extra treatment.
Can you tell, I mean, if the cancer is going to stay in the duct or invade? I mean, is it always surgery, or do you maybe watchful wait?
I mean, it's challenging. I mean, some patients may not be fit enough, you know, or strong enough to go for surgery. And in that case, maybe watchful waiting is the right way to go. But in most cases, I think if it's safe to do so, surgery is still happening. I think, you know, in some of my older patients in the clinic who even have an invasive breast carcinoma, at times they do choose a watchful waiting approach because, you know, they're a little bit fearful, at the age of 80 or up, that, you know, the risks of undergoing surgery. And in those cases, sometimes we have very effective therapies like hormonal pills, for example, that are generally effective and easy to tolerate. But that watchful waiting can be a challenge for some as well.
What about AI for screening?
As you train these AI programs to look at images, they become more and more sophisticated. And there's now already data coming out that, for example, in breast cancer screening, AI can detect more accurately than a trained radiologist because you fed into it information from millions of mammograms. So I think that more and more is going to become part of the screening milieu.
Is there a push for something less invasive to screen for gastric cancer, or is there anything on the horizon?
From what I understand, even in Asia, endoscopies are still king. So we had a visiting Korean oncologist that basically made a joke that you can go to a bar and have a drink downstairs and then go upstairs and get your endoscopy. So it's a cultural dynamic where they really accept that as the norm, right? Whereas here, because the incidence is so low, getting to see a gastroenterologist and getting that endoscopy, not for me.
I think I will maybe jump in here too, because there are some novel tests that are, you know, in development, looking at liquid biopsy. So these are technologies where you can do a simple blood test and potentially detect cancer cells themselves or fragments of those cancer cells really early, sometimes even before you see the cancer show up on, you know, our most precise imaging techniques. So I think this is a technology that's not yet standard of care, but there's a lot of research going on and some very promising results. So I think this is the direction of the future.
Okay. We'll be right back with more of the Zoomer. Welcome back. When you're diagnosed with cancer, one of the big questions is, who do you tell, when, how will it affect your relationships, your work, your livelihood? What's the right balance between privacy and disclosure? The twin British royal diagnoses put these questions in high relief. Neither King Charles nor Princess Kate have disclosed what kind of cancer they have or what stage it's at. How have their approaches impacted the public? Zoomer News videographer RJ Grubb took to the streets to get reactions on whether we should know more about what's happening with the royals. Take a look.
Unsurprisingly, the British royal family has found itself amid controversy, but this time it's due to health concerns.
In recent weeks, I have been most deeply touched by your wonderfully kind and thoughtful good wishes for my health.
First, King Charles comes out with a cancer diagnosis after an enlarged prostate surgery, and then Princess Kate seemingly disappears after a planned abdominal surgery.
It had been 9 weeks since Kate and their children had been seen publicly. On March 10, the royal account posted this picture, and oh boy, almost instantly it became clear that the photo was edited, like very edited, and not very well either.
The hashtag #WhereIsKate had been trending all over social media and had media companies digging for answers. All this prompted this heartfelt message from Kate.
I underwent major abdominal surgery in London, and at the time, it was thought that my condition was non-cancerous. The surgery was successful. However, tests after the operation found cancer had been present.
Kate let everybody know that she was diagnosed with cancer. But was it right for the public to force this confession? Let's see what the people think.
Not at all, no. She should not feel obligated. The world doesn't need to know intimate details of her life. Also, she's not the queen yet. I mean, doesn't she get to have a private life?
Well, I think it's unfortunate. She does have a very high public profile, but I do believe she has the right to privacy, just like anybody else.
Let people know what's going on, because, there were too many things about her doctoring her pictures and et cetera, et cetera.
It's definitely nuanced because obviously, I feel like everybody has the right to privacy, but at the same time, she's like a public figure and part of the royal family.
On an issue like this, there seems to be no right answer. Those who idolize the royal family want to give them their privacy, but also stay in the know. One thing is for certain, everyone is wishing for the continued health of King Charles and Princess Kate. Back to you, Libby.
Okay, thanks, RJ. Now, these are two very different situations in the same family. Charles has responsibilities as head of state. Kate does not, but neither is she a private person. And she is very young to be going through this. But still, their responses affect their subjects' approaches to the big C. And is what they're doing helpful or not? Kerry.
I think they have an absolute right to privacy. I mean, I think that one size definitely does not fit all. And, people often talk of the culture of cancer, and there's a lot of complaint from the public that the culture is, the truth shall set you free, you have to be positive, you have to crusade, and, there's a lot of people where that's not the case. I must say, though, if I was a communication expert, which I'm not, I would say it was a lesson in how not to manage communication, and I think we can all see that. But having said that, they really don't. The problem now is you've got, yes, there's cancer, but now it stops. And that's not really how human psychology works, because everyone's thinking, what's next?
Well, I mean, aside from the fact that people are thinking the worst, so if you have responsibilities like he does as a head of state, I think you have more of a responsibility to disclose. Mm-hmm. But if you're somebody who is such a huge role model, I mean, I think she was just very emotionally devastated by it, and that led, but it brought all these conspiracy theories. And to me, her explanation, I mean, and we didn't see the whole video again, but it was a bit fudged.
Yeah.
It
left me wondering, and I think it left a lot of people wondering. And he does, as a head of state or a significant role within the state, yes, facing health problems, but how far one goes following that. But, for her, she has 3 children. I can't remember if they're all under 10, I'm not certain, but she has 3 young children. So in her own life, she's facing something very, very serious.
Well, yeah, but I'm sure she has a lot of help dealing with that.
I almost wish, though, she would just take it a step further. Now that that cat's out of the bag,
Yeah.
obviously, you know, this is a controversy, privacy and all that, but now she has this platform to raise awareness about whichever cancer that she's facing, right? I think, you know, if it is a rare disease, this is a really good platform to raise awareness about screening and about that cancer is not a deadly disease.
Yeah, I want to get to that whole issue about how deadly it is. Now, I know you believe in their total right to privacy?
I think we all have a right to privacy when it comes with our own health, and I don't think the public has a right to know. I'm pretty sure, in fact I know, that there have been many public figures who have gone through a cancer diagnosis and treatment without ever disclosing that they even had cancer, and that's their right. I think at least in this case...
You probably treated some of them.
Possibly. But I think in this case, they did at least come forward with the fact, that, particularly the king, that he was upfront, I have cancer, I'm undergoing treatment. I don't really think that we need to know what stage it is, what treatment they're on. I think perfectly that's their right, even though they are public figures.
Hold that thought. We'll have more when we return. Welcome back. There have been huge advances in cancer treatment, but most people still react as if it is an automatic death sentence. So why is that, and what can we do to lessen the fear?
Well, they're deeply ingrained fears. Or the analogy I would use, too, is HIV is absolutely no longer a death sentence, and it doesn't hold the stigma. But I would agree that cancer is still this very fearful concept. You know, I state it cautiously, a lot of progress has been made, but a lot of progress also hasn't been made. A lot of people still get very sick and do die, and people know people that have died. And so the fear remains. And I think the small progress that I'm beginning to see is, what I hear from patients is the culture of cancer can be very problematic. We need a fighter, we need a warrior, we need this.
You know what? I think I agree with that. That's breast cancer. I don't think we have that in other cancers.
I hear it from other cancer patients. That's that toxic positivity thing.
Yeah, but I think it's mostly a breast cancer
Well, it's particularly breast that I've heard it from. But I mean, I think what is finally happening is we're beginning to look at cancer patients as individuals and say, you know, how do you want to proceed with this? And not kind of telling them what psychological attitude is best. I need a winner. I mean, I saw it when my mother had, you know, aggressive cancer. We need a fighter, we need a winner, we need... My mother said, I'm none of those. I know. She said, I'm not even on those lists, right? It's not me. But, you know, it kind of got pushed over. But you're very right. I don't have a perfect answer for it. Maybe my colleagues do, but cancer is still this horror of a diagnosis.
Well, the breast cancer thing, and I remember, I mean, I can't even count the number of people who will say to me, oh, you're doing so well because you have a great attitude. It's like, you know, all those people that died, they haven't died of a bad attitude.
No, I know. Also, your attitude's your own business, you know, like,
I mean, and it comes from there, that culture, like with the big smiley face. And
it's
I
smiley
think, like,
and it's military, and it's I mean, it's not as military as it used to be. But it's very stressful for a lot of people. I've known other people that are accomplished athletes that say, yes, it's the right culture for me, I'm going to fight. But it's not everybody.
And I mean, I don't even think fighting is the right thing, but you want to...
No, I was just going to say, I think everyone in this room probably has either personal experience with cancer, either they've had cancer, or they know somebody with cancer. So, you know, what I want to just highlight is treatment is changing. So I've been at Princess Margaret for about 3 years. I can say, you know, we initially started with giving chemotherapy, generic chemotherapy to every single person with a certain disease type. Now we're at the cusp of history. We're now introducing personalized medicine. We're looking at patients' biomarkers and trying to target not only just the generic chemotherapy or immunotherapy, we're now personalizing treatments for patients. So I see a lot of hope right now. Access to biomarker testing, that's another issue that maybe I'll leave at the door for now. But I think in the future, hopefully, every single patient who is diagnosed with cancer will have biomarker testing and this personalized medicine. So I think there's a lot of hope to the future, and we're just scratching the surface.
Yeah, I mean, hey, I was there with the big cancer, and I have no cancer.
Exactly.
So there you go. But the fear of it seems to persist despite the good news that comes. And even one of the other things that makes me nuts is every time, and it's a total cliche, and this is rampant in our business, in the media business, every time someone dies, they say, lost their battle with cancer. It's it's stupid.
Yeah, and I think the reason why a lot of people are so afraid of cancer, why we still have this stigma about it, is there are a lot of people who have cancer who never tell anybody. You don't hear about the people who quietly have cancer and they get past it and they live their lives and you don't know. And that's why I've been so very public when I was diagnosed, because I wanted people to know the things that I wished I could have found out. And so you get a couple of different reactions when you tell somebody you have cancer. You get that toxic positivity. You're going to beat this, you're a warrior. Or you get, oh yeah, my grandmother died of that, or my uncle had cancer and he died. I don't want to hear of all the people that you know that died of cancer. Just say, I'm really sorry that's happening to you. I don't know what to say, but that really sucks.
It's also the amount of diversity in our society has risen. And when you look at cancer reactions cross-culturally, they're profoundly different. And one of the problems is you've got a Western, very go-getter, autonomy-focused culture that's pushing people of different cultures in ways that they don't feel comfortable with. That's a big problem.
That raises a point about awareness and advocacy. So I can say that back in 2011, when I was diagnosed with stomach cancer, there was no Stomach Cancer Foundation. And now there is a Stomach Cancer Foundation in Canada. But in Asia, where patients may not share that diagnosis, even though it's the #1 cancer in Korea and Japan, there is no stomach cancer organization there. So it's about having role models. It's about knowing that there are survivors out there. It's about raising awareness, because let's be honest, awareness will raise funds, and funds will raise research, and research will bring treatments to patients. So I think it starts there.
I would agree with Katie. We are on the dawn of a new age, because we now, what's different now is we understand cancer. We understand why it develops, how it grows, what the genetic changes are, so that the treatments that are coming in now are focused specifically on these abnormalities that we understand in the cancer. And we understand also that everybody's cancer is different. Genetically, you can look at each cancer, and the treatment for 100 people with breast cancer may be different in different subsets, because genetically they have different diseases. And that's what's coming in. I think the public has been hearing for 30 years about breakthroughs in cancer, so they become understandably skeptical. Oh yeah, we always heard that. But it is different now with immunotherapy, with what's called personalized medicine. I think we are starting to see meaningful impacts in the clinic. So it will get better, and I think at a quicker rate than it has in the past.
That's a hopeful note to end this pack. When we come back, final thoughts from our panelists. That's enough. Welcome back to the Zoomer. It's now time for final thoughts from our panelists, starting to my left.
Okay, to reduce your risk of cancer, don't smoke, eat a reasonable diet, try to maintain a normal weight, and get screened. For males and females, colon cancer, females, breast cancer, smokers, lung cancer, women, cervical cancer, and as time goes on, I think the screening test will improve. So definitely get screened.
So you took the one what I was going to say, but I just want to really reinforce that for breast cancer, how important the screening is, and to remember that there is now a lower cut point for age 40 for women at average risk of breast cancer to get screening, and also for patients who have a high risk of breast cancer. So based on personal risk factors or family history, there are high-risk screening programs for women starting at age 30 with mammogram and MRI. So take advantage of those programs. Early detection is very important.
I'd like to mention that on the point of early detection, we need to have people start from a young age, get familiar with their own bodies, check their own breasts. Young men need to learn to check their testicles because testicular cancer is usually between 15 and 30. And we also need to reach out a lot to people of color, Indigenous communities, immigrant communities, and also the LGBTQ, non-binary, trans community, because they often feel excluded from the conversation.
So I think from the most recent Canadian cancer projections, although the number of cases of cancer are increasing, the good news is the actual rate is decreasing. We need to try and support diagnosis and pathways for diagnosis in patients with suspected cancer, though.
And I would say we also need a healthcare system that's going to function and not have firewalls and allow patients, as we've heard from the audience, to move forward. Emerging technologies are going to help, but the fundamental messages that we've heard from our colleagues about health are great. And AI, let me just say very briefly, artificial intelligence, I'll say as an ethicist, is a great worry. But when it comes to cancer, it could be a godsend. It's doing amazing stuff, and I think that's really going to help us all a lot.
And for me, I think, cancer is not one disease. It's often misunderstood, but it's isolating, it's scary, it's terrifying. Sometimes you feel completely and totally alone. Definitely trust your medical team. I promise you they will do the best that they can for you, but also reach out to advocacy organizations that can help guide you and inform you with good knowledge and support structure.
Well, cancer is no longer the automatic death sentence it used to be, but that's still the usual response to a cancer diagnosis, and the fear can be as harmful as the disease itself. Yes, it is terrible, and for all the advances, treatment is usually difficult and lengthy, but for millions of people, more every year, there is life after, and it can be a very good life. And that's it for us this evening. To get in touch, send us an email at comments@thezoomer.com. As always, thank you to my panel and to you at home. We'll see you soon. And now it's time to zoom out.